everyone. Myself, Dr. Priyanka, and I'm one of your mentors for Study MRCPI. So, today we are back with the AAA series for MRCPI Part 2 written, where we'll be discussing the important topics related to the exam point of view. So, today we'll be having a discussion on menopause and HRT NICE guideline. So, do like, share, and subscribe StudyMEDIC channel, and also press the bell button icon to get the updates on the recently added videos. So, always remember that a little progress each day adds up to big results. So we'll discuss the guideline on menopause and HRT by the NICE guidance. So what is perimenopause actually? So the period before when the patient achieves menopause, so the period before that is called as a perimenopause, where either the patient will have either clinically have irregular menstrual cycles, so they will be haphazard irregular menstrual cycles, or there also they may have vasomotor symptoms in the form of night sweats or night flushes or changes in the mood. So this is period is called as perimenopause, which is the period which is just preceded by the menopause. And what is menopause is when they do not have a period for consecutive 12 months and they are not using any hormonal contraception. They shouldn't use any provided any hormonal contraception, and they have not had any periods for consecutive 12 months. It is called as menopause. And what is premature ovarian insufficiency is it is menopause-like associated symptoms that includes infrequent or no periods, and also the woman who is aged less than 40 years. So that is called as premature ovarian failure. And the diagnosis is by only by doing the lab test is by doing the FSH values that are done 4 to 6 weeks apart, two samples which should be in the menopausal range. So, as we know that the symptoms of menopause can be, it can be due to difficulty in concentrating, or there can be hot flushes, night sweats, there can be anxiety and depression, there can be loss of libido, and there can be irregular pain, joint pains, fatigue, and also there can be breast pain. So there will be a lot of there is a lot of a spectrum of symptoms which can happen in menopause, and which can be socially disturbing for the woman, and hence treating these symptoms is very important, and also which will improve the quality of the life of the woman. So knowing the symptoms and treating them is very important. Also knowing the risk factors is very important in the woman, especially because we will be prescribing the hormone replacement therapy, which will consist of the estrogen and progesterone component. So history taking before prescribing the HRT or any other forms of other hormone replacement therapies, knowing the history is very important. If they have any specific risk factors like any family history of any or a personal history of cancers, or if they have a high BMI where certain HRTs are not indicated, or if there is a liver disease, any history of breast carcinoma. So all knowing this is very important. Any previous history of venous thromboembolism. So all this should be taken into account. A detailed history should be taken. Followed by that, a proper clinical examination should be done from head to toe. The first is the general examination, knowing the pulse, blood pressure, and the BMI, and then followed by the respiratory cardiovascular examination. Then the per abdominal, local, and per vaginal examination should be done. And then followed by that, according to each patient, the management is tailored. So for the vasomotor symptoms, the first line of management is the hormone replacement therapy for vasomotor symptoms. And the second line is the cognitive behavioral therapy. So it can be in addition to hormonal replacement therapy, or it can be given, the CBT can be given in those in whom HRT is contraindicated, or those patients who deny HRT, in them cognitive behavioral therapy can be that line of treatment. And regarding the selective serotonin or noradrenaline reuptake inhibitors, the recommendation by NICE is that it is routinely not used because of the side effects they have. So for the vasomotor symptoms, the most common use is the hormone replacement therapy. For genitourinary symptoms, when the patient comes with like a atrophic vagina, so in them, or like dyspareunia, for example, or like any associated with dryness of the vulva and vagina, in them the history of knowing the breast cancer risk should be asked. So if they have no history of breast cancer, or the risk is low, In them, the first line of management is always the vaginal estrogen. It can be given in the form of cream or gels, tablets, pessaries, or ring. And the second line option is non-hormonal moisturizers and lubricants. So they carry low risk than the vaginal, but vaginal estrogen has been found to be more effective than the other non-hormonal methods. Then the other medications are vaginal prasterone. So it is nothing but the dehydroepiandrosterone. So it is an steroid which is given, which especially in case of dyspareunia. So it is usually given when vaginal estrogen and other non-hormonal medications are ineffective. And also the nice recommendation is to consider ospemifene. So it is a selective estrogen receptor modulator. So which can be given in case if they do not have history of breast cancer. But if they have a personal history of breast cancer, so in them, the preferred are the first line management is the non-hormonal, because the hormonal carries an increased risk of breast cancer. So non-hormonal moisturizers and lubricants are the first line of management in case of personal history of breast cancer. And vaginal estrogen can be used if other all the non-hormonal methods are ineffective. And vaginal laser treatment for the genitourinary symptoms is usually not indicated. So the patients can come with depressive symptoms. So in them, again, an HRT is the first line of management, followed by cognitive behavioral therapy. If they have sleep problems, sleep disorders, so then a cognitive behavioral therapy is the first line of management. And if there is a loss of libido or altered sexual function, so we know that giving the supplementation of testosterone it will be very helpful. Tibolone can also be given. So there are some special considerations where a specialist advice is recommended for prescribing the hormone replacement therapy. So it will be by a multidisciplinary team, especially in case of type 2 diabetes, or if there is an increased risk of venous thromboembolism. So here, if there is increased risk of VTE, so it will be an MDT which will consist of the referral to the hematologist, and also in them the oral, as we know, then oral HRT is associated with increased risk of VTE. So in them, a transdermal preparation rather than oral is used. And if they have history of personal history, especially of coronary heart disease or stroke, so again, then it will be by referring them to the specialist cardiologist and then prescribing HRT under their guidance. So in November 2024, the recommendation came that the use of combined or estrogen-only HRT in people with active or recent arterial thromboembolic disease was off-label. So what are the effects? So effects in different conditions. So what are the effects that HRT can have in different conditions? So the HRT, the combined, whether it is a combined HRT with progesterone or if it is only estrogen only HRT, it is unlikely to affect the life expectancy. So what are the effects in the on the breast cancer risk? So the breast cancer risk increases with the combined HRT. So it increases because the progesterone is the culprit here in breast cancer. So it increases with the combined HRT, and the more the time it is used, the risk is increased with the duration. And also the effect lasts till 10 years. And or regarding the endometrial cancer risk, so the endometrial cancer risk, it decreases with continuous combined HRT. So here we know those who are having a uterus, so we usually do not give only estrogen HRT, because we know that estrogen only can cause endometrial hyperplasia and subsequent risk of developing endometrial cancer. So here in them, continuous combined HRT in the form of estrogen plus progesterone is given, so that progesterone causes thinning of the lining of the endometrium. But it may increase with sequential combined HRT. So it again depends upon the duration, how much is the progesterone given. So the fewer the doses of the progesterone given, then it may increase the risk of endometrial cancer. And ovarian cancer, so again, it has also been increased with the combined HRT. There is slight increase in the risk. And in case of coronary heart disease, the risk does not change with combined HRT. So regarding dementia, so yes, dementia risk is increased with combined HRT if it is started late, if it is started at the age of 65 or over. And regarding muscle mass strength, so here the evidence is limited, but they suggest that HRT may improve the muscle mass and the strength. So what is a recommendation regarding the relation regarding osteoporosis? So it is very well known that HRT is given while for those to decrease the risk of osteoporosis, especially those who are having premature ovarian failure, or examples like in case of Turner syndrome also we give them HRT till the age of natural menopause to decrease the risk of osteoporosis. So yes, it decreases the risk the HRT, and also, but when the HRT is stopped, then again the risk of osteoporosis is increased. So regarding stroke, the stroke, it is more with those with combined HRT preparations, especially oral preparations, the oral estrogen component. The higher the dose, the higher the duration, the higher early starting of HRT, with more estrogen content, there is increased risk of thromboembolism and stroke. Then coming to type 2 diabetes, the risk does not increase with HRT. And for cardiovascular disease, the dementia prevention, for sole dementia prevention, the nice recommendation is to not to recommend combined or estrogen only HRT, just to prevent dementia. Yes. So guys, that was all about the HRT, menopause and HRT, where we know that the symptoms of menopause can be deteriorating, and then prescribing them with proper tailoring according to each patient's needs and their risk factors is very important. So that was all about HRT. So always remember that those who are having a uterus, for them always prescribe estrogen plus progesterone HRT, and those without a uterus and those who have less risk of having the cancer risks, so in them only estrogen only HRT can be prescribed. So that was all guys about the menopause and HRT. Thank you for attending. Thank you so much.